What an incredible panel. So much wisdom and learning. And I would like to, this is the time where we can take questions and answers from the floor. And I've also got some questions that have come through the website, sly.do. And so I'll invite Kathy, first question from the floor.
My name's Kathy Kastner, and I have a website called bestendings.com, which is, in fact, about best endings. This is so inspiring, and I'm so glad that this is being videoed so that it can get to the wider audience. My question, being involved in the virtual universe of health, is I wonder if there are any plans and path to bring that community element to it so the connectivity between users can be expanded to peer-to-peer support. Aha.
Who would like
a scary
to take
question.
That? Linda, do you want to give that a go?
Are the mics on? Yeah. Okay, great. So
handheld. Sorry, the handheld.
Okay. Are they on?
Do the dance of the handheld. Pass the handheld. Don't drop the hot handheld.
All right, we're on.
You are on. No.
Good. I think from my perspective, what I have seen, peer-to-peer support has occurred in the meetings with the individuals, the social get-togethers. There certainly is the peer-to-peer. In terms of online or virtual, no, at this point in time. Now, Wendy, any thoughts from your perspective?
That's something that we're always thinking about, right? How do we utilize the platforms that we develop?
Do you want to stand up, please?
Yeah.
And yes, at the mic. Thank you.
So that's something that we're always thinking about and talking about. How do we use the platforms that we've developed to increase that capacity for those connections, right? So we've talked about things like having a place on the website where caregivers, for example, can communicate with each other and say, you know, I'm having this issue. Is anyone else having this issue? How can we share those kinds of things? So although we're not there yet, we've had lots of feedback that we need to think about continuing that process.
Yay!
Terrific. Thank you very much. Thanks, Kathy, for your question. Walter, would you like to come up to the mic and answer these questions? The questions, I love it when the really smart person's on the hot seat over there. Walter, we'd like to know about who received the weekly measures report. Like, what was the process? Did it go to the participants as well as and who else? And then the other question was asking about the low number of weekly responses. And you said there were 120 people involved, and it looked like there was a low number of responses. So could you answer each of those for us, please?
Sure, great. Thanks, both questions being excellent questions. The first one is who it goes to, the report. So initially, there are most of the members of the steering committee, so they are representatives then of the family health teams, the community care, the partnership, hospital, primary care, and actually a number of people within the PATH team. And then actually our timing of the Monday reports was so that it would get to the frontline PATH team. So their meetings were on Tuesdays of each week, and I'm kind of doing a dance so people can see. Tuesdays of each week, so that was part of the timing of having a Monday report, so that frontline PATH team that met every Tuesday morning would have that information to review what things had happened in the past week, and then also where they'd need to engage. So then some of that information then made it out to the coaches as well as to the patients themselves. And those are the main two audiences to this point in time. Second question was around the number of responses, which on any given week ranged from about, it could be as low as 6 and up to 15 to 20. And that's a matter of how many encounters these people are having. So, and what their own desire is in terms of which ones they want to report on. So people don't necessarily want to spend all of their time entering their experience information into a tablet. But after key ones, they would, right? And so if we figure you're not necessarily seeing key providers on every single day, I think that's about the range that we were experiencing. So we haven't, and there are more active and less active users. So I'd say of those 120 people that are using it in some ways, that probably about just over, they've all entered some experience, but I'd say there's probably a little under half are active users that we see on a very regular basis.
Terrific. Thank you very much, Walter. We've also got a question for Chancellor. Where's Chancellor? You are at the back. There you go, and you've got a mic. That is so terrific. We've got a question for you that is about asking who finds the tablets and how do you determine which patients receive them? And how many tablets in ratio to the patients? I would hope that that doesn't mean, does one patient get 3 tablets? But can you help us understand that whole process, please?
Can you hear me? Yes.
Yes.
So Chancellor Crawford.
How about if you stand up so we can all see you?
Very tall, so very hard to
Fantastic.
miss.
Thank you, Chancellor.
So with the Chancellor Crawford from QOC Health. So for the tablets and the mobile technology, what we really try and look at is how do we create equal access to the technology. So what we want to do is be able to provide a program where patients will be able to use their own devices, so bring your own device, but where patients may not have their own devices, we want to work with partners. In this case, we worked with Samsung to do a managed device program so that we could provide devices for the patients as well.
So would that mean that if you could use it on kind of Android, like Samsung or Apple?
Yeah, so if you had your own iPhone or you had your own tablet, you'd be able to bring your own device and be able to access the tools directly.
Fantastic.
If you had your own mobile phone. The challenge is that some of these mobile devices and technologies can be quite expensive, and sometimes they're not accessible for everybody. So how can we make equal access to the technology for everybody? And we can do that through managed device programs, where we can provide devices for the patients and use them while they're monitoring the conditions, and then they return them back.
And another question that came up was about privacy. How did you ensure privacy? And is there a way to give other folks, other than the patient and their primary caregiver, access to the information?
Yeah, so when we talk about privacy and security, we're really kind of dealing, well, two parts of that is the privacy, and the other part is the security. So the security is really sort of the nuts and bolts, so it's the encryption, how are we handling, ensuring that the information is protected while it's on the database servers, while it's being transmitted. But the other aspect that's really important is privacy. I think that privacy really deals with the aspect of consent and disclosure. So how are you ensuring that you're telling the patients how information is being shared, and where are you providing patients the opportunity to consent to that sharing? And that's what we've built into the whole platform, so the patients are a part of that consent process.
Terrific. Thank you very much.
You're welcome.
Linda, this question is for you. And the question is, what is PATH's sustainability plan? I do believe that means, how are you going to keep it all going?
Well, I think I would refer to the comment that Jack made earlier in terms of the momentum, the pull, the magnetic pull. We do have a sustainability plan that we have developed a business case for. We will be looking to share that widely with potential funders. We believe there is a magnetic pull that can happen. When you hear individuals like you just heard this morning talk about PATH, this is something that needs to grow, it needs to develop. So there is a business case ready to go. We are hoping to approach both the Ministry of Health. We've tried to approach for a number of grants as well in terms of sustaining it and growing it.
Fantastic. Thank you. With the lights, I think that's you, Sheila, is it?
Yes, thanks. Hi,
Great.
Sheila Maloney from Canada Health InfoWay. A great presentation, really enjoyed it. A couple of questions, if I may. I'll ask them and you can decide whether you're going to answer both. You talked to 120 patients. Wondering if you can give us a sort of an overview, average age, who they are, what kind of, how do they self-select, how are they into the program? And then my other question, Jack, you talked about, you were coaching somebody and they graduated from the program, or you're not coaching them anymore. And I'm wondering how you decide, or is there a certain protocol, they only get certain hours of coaching, or how that works?
Like, how do you graduate?
Yeah.
And is there a ceremony and a certificate and all of that? Because it sounds like quite a milestone. First, who would like to? Wendy. we're going to ask Wendy.
To the transition coach one, but I can, so how do we recruit patients? This is interesting because at first we recruited seniors who were part of the practices of the family physicians who were part of the pilot. But what we learned really quickly was we had lots of calls on lots of people who wanted to be involved but didn't have one of the physicians who were part of the original pilot. So we made a decision to actually open it up because we learned really early physicians don't have to be part of the pilot for seniors to have benefit from it, right? And lots of our seniors see physicians outside of our area, so we opened it up to others in the community as well.
Fantastic. Thank you very much. This mic over here.
The other question was
sorry, the other question. Sorry, please, Chuck. Thank you for keeping me on track. I really appreciate the support.
The question, I think, was graduation.
Oh, yes, that's right.
It's not quite that formal. At the outset, we set up a service plan with each of the patients, and you have some goals and objectives that you put out in that service plan. And you know, after 3, 4, 5, 6 weeks, could be 2 or 3 months, who knows, whatever works for that patient, when they're comfortable that they've achieved their goals and they're comfortable with the system, putting the information in, tracking it, they feel that they're now ready to be better prepared when they go to meet with their doctor or any of their other healthcare providers, then I think you just mutually know that, you know, your job is done. But there is a follow-up. 2 weeks after we kind of close out the file, we will call the patient back and just chat with them about how they're feeling. Is everything going well? Have you had any more issues, any problems with the technology that might need to be addressed? And if so, we'll go back and meet with them again. And then I believe as well, Kelly is planning on doing an additional follow-up on an ongoing basis, you know, month 1, month 2.
Terrific. Thank you very much.
Question for Walter. I'm wondering how you've managed to deal with, or if you've had to deal with, survey weariness.
Are people getting tired of filling out all those great questions you have?
Yeah, so people haven't tired entirely, and I'm seeing here, like, you know, on this report, we had up to date about 37% of the people reporting in the past month. It's voluntary, right? People do what they want to do. So you see there's a bit of variability. So the first question up was, why don't we see, you know, 120 patients on each time point? You know, that's not what we report in every week, so we don't push. We want it to come from them. There are a few touch points that we do try and get some of the baseline measures around their own activation and their appreciation for how well coordinated their care are. And we're very cognizant. So we had measures that people can report based on their experiences when they wanted, at any encounter time, point in time, and that's entirely voluntary. It's what it works for them and their own measures in terms of their chronic conditions as well. It's the same thing. We have providers that we ask to report in each week, and then otherwise there are a couple of measures from the patients that we look for on a monthly or quarterly basis. In the longer surveys, the only tools that are more than 10 items are on a quarterly basis. So we're, I think, keeping the burden down low.
Terrific. We have time for these very short questions. We are otherwise, may I invite you to the...
My question's very long, so I'll just sit down then. Just kidding. My name is Brad Holman. I'm the past chair of the Hanover and District Hospital and also an OHA board member. Yeah. My congratulations to you. I think it's a wonderful program. Empowering the caregiver, you know, to improve the patient experience is wonderful. And being the caregiver for some very elderly, frail parents, I wish they had that in their areas. My question is, given that the doctor's reports and the lab reports are uploaded, I gather they're uploaded in real time. So is that available to the caregiver and the patient real time? And if that is a fact, is it possible that they could read one of the lab reports or diagnosis prior to their physician? And given the fact that it could be life-altering or life-ending, is that a problem, and has it been a problem, and how is that handled?
So yes, the DI reports, and I think soon we'll have OLIS reports on there from the labs. What has to happen first is the patient would have a visit with their primary care provider. And once the discussion has happened, the physician can, or the provider can then push the report to the patient portal. And then the beauty is the patient has it as they transition from one physician to another if they have to see a specialist, or even if they go to their pharmacist, they get to choose who in their circle of care they wish to share this information with.
Sure.
And so then it's in their hands to take on their transitions between different care providers.
Thank you. Last question.
A little bit of a follow-up. Given the success with the relationship that's been established, you can actually discuss these results. Are there any prospects, you see prospects for these actually being integrated into a shared interactive electronic medical record rather than having something over and above?
Okay.
Yeah, I think the beauty of this project and what we've been realizing is the opportunities are becoming endless. And we're at I think somebody said it, we're just scratching the surface here. And we've been, we've had to guard against overextending ourselves because what we're seeing is so many possibilities, and we really had to keep focused on the project, the elements of the project. But there's many questions here, the peer-to-peer, exactly what you're saying. I think the opportunities are endless, and I think we have to start asking ourselves, okay, what is the next best project to take on? But I think it's important that we do look at how do we integrate this into the hospital information systems or the healthcare. And it really should be, I think what we're starting to see, if we're really going to move to a person-centered model, the chart really needs to belong to the patient.
Yeah. Hear, hear. Thank you.